Lovely. We'll get going with the introductions now. So, hello, everybody. Welcome to this Meet the Experts webinar today on anti-D immunoglobulin errors and immune anti-D cases. This is the next one in our Meet the Experts webinar, and it'll follow a similar format as we've had before. Just to let you know that your cameras are going to remain off and your microphone muted throughout the webinar, and the chat function has also been disabled. So to take part in the Q&A, please use the Q&A box. It's there at the top of your screen. The live captioning is also available, and you can disable that following the instructions below using the More button. There'll be no certificates issued for this webinar, but we'd encourage everybody to record CPD through effective practice, and the recording is being taken of this event and it will be available on the SHART website soon. Lovely, thank you very much. So I'm going to introduce some panelists for the webinar. Unfortunately, we don't believe that Dr. Jennifer Davies has been able to join us today, but if she does, Jenny's got a wealth of experience with anti-D errors, and she's a transfusion laboratory manager at Royal Devon Hospital. We're also going to be joined today by Clare Cook. She's a patient blood management practitioner in NHSBT, and she's a very valued member of our SHOT working expert group for anti-D errors. You'll also be joined by the SHOT incident specialist, Vera Rosa, and she's the specialist for anti-D errors, immune anti-D, and avoidable delayed and under transfusion and near-miss WIBIT. And then we're also very lucky to be joined for the Q&A by Heather Clarke, who's the RCI development lead, and she'll be fielding some questions to do with anti-D from that perspective. As well as that, there's also a lot of support from the SHOT team. For that, we're very grateful. Thank you. So just a quick overview of the webinar. This is our first one on Microsoft Teams. So thank you for your patience for any glitches, but I'm sure everything will go very smoothly. So the overview is we're going to talk about anti-D IG errors and immune anti-D data. Then we're going to follow on for some case studies, and then the normal extended Q&A session, because this is a Meet the Experts webinar today. The last part from me is just to assure you that all cases that we're using in this webinar have been anonymised, and they're all really reflective of the information that has been submitted on the SHOT reporting system on Dendrite, and they're only being shared today for the purposes of education and for learning. So that's the introduction all done. I'm going to pass over now to Clare for the rest of the webinar. Thank you.
Thank you. Thank you. So the current criteria for reporting to SHOT, this is including errors that relate to the requesting and administration of anti-D for routine antenatal prophylaxis, responses to PSEs during the pregnancy and again at birth, so after delivery. Now, it also includes administration of anti-D following D-mismatched solid organ transplant or transfusion of D-mismatched blood components. And of course, that includes paediatric patients as well. Now, anti-D errors, and sorry, if you could just pop back one for a second. Anti-D errors and immune anti-D, these are two distinct categories. Now, sometimes two reports are going to be required. Reports for immune anti-D, this includes women who've produced immune anti-D detectable for the first time in the current pregnancy, whether that's detected at booking, 28 weeks, delivery, or any other time in the pregnancy. And all cases of immune anti-D should be reported, and that's regardless if there was an error, if there's a perceived non-compliance, so the woman couldn't turn up for any appointments, or even if there's like no identifiable reason, because it helps SHOT to build up a better picture and understand the causes of continuing anti-D immunisations. Now, if there's an error administering that anti-D, then that might have caused the immunisation, then a separate report would need to be submitted for the anti-D error. And then looking at the next slide, what we can see is looking back at the data over the number of reports over the last 10 years. Initially, post-COVID, it went down, but what's happened, it's steadily been rising back up, and we're now back at the numbers pre-COVID. Now, it's interesting to know that the anti-D errors category, this is the category that remains consistently the highest reported category to SHOT, excluding the large near miss category. Now, the next slide, what this is showing us is that we're going to focus mainly on the main categories for the 2024 anti-D errors chapter. And you can see from this that the lion's share is really taken up by omissions or late administration of anti-D. Beneath that, we've got anti-D given to people who've got a D-negative baby, wrong doses of anti-D being given, and then anti-D given to people that have already got immune anti-D. But the bulk actually comes from the omissions and late administration. So within that category, It's fairly equally spread across all the different stages of pregnancy. You can see we've got 91 cases that occurred during routine antenatal prophylaxis, 98 cases where it happened during a potentially sensitizing event during the pregnancy, and then another 93 happened at delivery. When we break it down further, routine antenatal prophylaxis, now the most common cause in this category was anti-D not being ordered, and that happened for 47 people. Now, another 34 people, their appointment never actually was booked in the first place. For the potentially sensitizing events, there were 37 people discharged before that administration, 24 people, the anti-D was never ordered, and then in 12 cases, this was due to an incorrect decision by their healthcare provider, so they actually chose to omit and not give the anti-D. Now, within this category, we've got a couple of sub-reasons that cropped up quite frequently. One was a lack of an effective checklist, and the other one was a knowledge gap on the part of the healthcare professionals. When it comes to delivery, 39 people were discharged before administration. There were 10 cases where there were transcription errors. There were 10 cases where the anti-D was ordered, but it was never administered. And again, sharing sub reasons, there was a lack of effective checklist here as well. Now, one thought that frequently occurs to me is how much did the women understand about the implications of anti-D, or more importantly, the implications of not having anti-D? You know, were they given enough information? There's lots of sort of questions why. Now, the next slide, this one's looking at the actual number of reports for omissions and late administration. And what you can see, we've got the same pattern occurring. So in the 5 years preceding the 2024 report, it initially dropped post-COVID, but what's happened, it's continued to increase, and now it's exceeding that year's figures. And this led to the release of a safety notice back in December 2024. So the safety notice went out, and what it did, it kind of outlined the scale of the problem to people, and it's offered some tools to organisations so that they could perform their own gap analysis and try and identify lots of opportunities for improvement. And so what we'll do now is we'll look at some case studies and what we can actually see from the first one. So this was shared care. Shared care frequently kind of pops up in the monthly reports. It's like an ideal opportunity for people to kind of fall through the cracks. And this one was complicated by a D variant. So during the pregnancy, mum was being looked after by her local community midwives at her local hospital. But due to another medical condition, she opted to deliver at a different hospital. Now, in the local hospital, she was identified as D positive, and correctly, according to that protocol, she was never offered anti-D through the pregnancy. However, when it came to the delivery hospital, they questioned the D status, and so they sent a sample off to the reference lab, who later went on and confirmed that mum was D variant. Now, in the meantime, the delivery hospital contacted that community team and said they really ought to be treating her as D negative. The delivering hospital at the time, their policy was that they wouldn't do the fetal maternal hemorrhage, and they didn't follow up and administer anti-D. It was all handed over to the community team. Now, they acted on the advice, they called the woman back in and they took the samples, but unfortunately they mislabeled, and so these were rejected by the lab. Now, what happened then was that they had to repeat follow-up fetal maternal hemorrhage sample, but they'd missed that golden opportunity of the 72 hours, so it was given late. Now, the learning from this event led to the hospital changing their policy, and going forward, community midwives, where there's shared care, they would put in a request to that delivering hospital to complete the testing and complete administration of anti-D so that the woman had continuity of care. So this case kind of highlights quite a few opportunities where people have fallen through the cracks of two different carers, with the added complication of the D variant kind of slowing things down a bit. And so Jen is going to carry on with the next few case studies. Jen Davies. You
Yes,
okay
thank
there?
you,
Yeah.
Claire. Yes, sorry, just struggling with the camera there. Thank you very much. So obviously the anti-D, safe management of anti-D is challenging, and errors can occur anywhere in the pathway. And you can see from this chart that they're most likely, or that we see most of them in the decision and requesting stage, and then again in the product collection stage, but they can happen anywhere, and we've got some cases to share with you. So on the next slide, this case then describes an unnecessary administration of anti-D-Ig, and in this hospital a list is sent to the lab for the issue of the anti-D. And the BMS in the lab noted that one of the women on the list did not need anti-D-Ig because the fetal D screening test predicted a D negative baby. However, whilst booking the person's details onto the computer, the BMS was distracted and recorded against a record of one who did need anti-D. And on the day of the clinic, the midwife noticed that there was an anti-D-Ig missing for one person. So the missing dose was then issued by the laboratory. The BMS, though, didn't inform the midwife that a dose had been issued for another woman who didn't need it, as they assumed that the midwife would check. But unfortunately, the woman who didn't need anti-D was then given an unnecessary dose. And this case really highlights distractions and assumptions that can contribute to errors. And there was also an underlying theme of inadequate staffing levels as well. And also the midwife not checking that the anti-D was required before going ahead with the administration. And improvement actions were put in place both in the laboratory and in the maternity services as well. So fetal screening for RHD, which we sometimes call cell-free fetal DNA or cfF-DNA, this has been available in the UK now since about 2016. And it's been hugely successful in terms of targeting anti-D-Ig to those ladies predicted to be carrying D-positive fetuses or where the D-type can't be determined, and so avoiding unnecessary administration to those carrying predicted D-negative fetus. And so it's a fantastic thing that's come in here, but the programme, unfortunately for us, has introduced new challenges with safe and appropriate management of anti-D-Ig. The assay itself does have a small risk of false positive results and an even smaller risk of false negative results. And we do ask that those are reported to SHOT, even though they may be unavoidable. And we also recommend that when you're picking up false positive or false negative from cord sample testing, that investigations are performed to ensure that the cord D type is not the result of a wrong blood in tube or a weak or partial D status, and that means that anti-D can be given, if appropriate, post-delivery. False positive and false negative results should also be reported to the reference lab as well, as per their individual requirements. The screening programme, though, has other challenges that it's brought for us, which contribute to error, and they're shown here on the chart for the 2024 data. And these include gaps in knowledge relating to the results, again, ineffective checklists, individuals not checking the result either in maternity or the lab, and now looking at results from a previous pregnancy as we're quite a few years into this programme being available. And also the lack of IT algorithms to support safe practice as well. Next slide. So in England, if you can go on to the next bit, that would be great, thank you. So in England, the majority of fetal D screening tests are performed at NHSBT, and then the results and recommendations are released onto the electronic reporting system, which is called SPICE. And then these either need to be downloaded by the laboratory or the midwifery teams, and then they're most likely transcribed into other IT systems. So clearly there's delays in this process and risks of transcription errors and challenges also with visibility of results. So it's great news that the NHSBT have been piloting an electronic ordering and resulting process using Labnostics, which is led by Heather Clarke, who, as was said earlier, is here with us on this meeting and will be able to take questions later on. And I think this is going to make a huge improvement to this process, not only in terms of risk and timeliness, but also for staff efficiencies in laboratory and maternity services as well. And then another challenge that we have with anti-D is that where cell salvage has been used and reinfused to the patient, a dose of 1500 IU is required rather than the dose of 500 IU, which is quite often the standard dose in many hospitals. And in this case, during a C-section, cell salvage blood was collected, but the anaesthetist initially decided not to transfuse due to the low volume collected. And so when the clinical team contacted the laboratory, they informed the BMS that cell salvage blood had been collected but not reinfused. And so the lab issued their standard 500 IU anti-DIG. But later, during an audit, the transfusion practitioner found that actually 130 ml of cell salvage blood had been transfused to the mother, and that had been recorded in the patient notes. And the investigation showed that the anaesthetist had actually changed their mind about the cell salvage and had been reinfused, but the laboratory hadn't been informed. So this just really shows the importance of good communication between teams. Thank you. I'm going to hand over to Vera now.
So now we are going to talk about another case where the anti-DIGG error led to deimmunization. It was a large postnatal FMH. It was 166 mils. It was given anti-DIGG doses. It was given intramuscular, and a follow-up sample was requested 72 hours post-administration. A follow-up sample was taken, but it was before the 72 hours were up, so this sample was accordingly rejected by the lab. So the midwife contacted the mother to attend the maternity triage at 72 hours to take a new sample. However, on the maternity ICD system, the midwife did not record the reason for that appointment. The mother, unfortunately, the baby was in NICU, so the mother only attended maternity triage 3 days after the 72 hours were up. So, but the patient came to the mother came to the appointment, but the requirement for a new sample, for a new Kleihauer sample, was not identified and it was not taken. The need for a follow-up sample was just identified when the lab called the clinical area chasing for this sample. So the mother was called back to attend triage, and a follow-up sample was taken, but this was 122 hours post the anti-DIGG administration. They have carried out a follow-up appointment 6 months post-delivery, and at that point, immunity D was identified. So why we are talking about anti-D-IgG administration errors? Why do we look at them? Why it is important to give the anti-D in a timely manner, the correct dose? That is because of the impact on the pregnancy. So sometimes, as Claire said, we request for 2 reports, one for anti-D-IgG error if it occurred, and then if the immunity D was identified first time during the pregnancy, we request for a second report, and that is the anti-D immunization category. In 2024, we received 68 cases where immunity D was developed during the pregnancy. As you can see, most of them result in live birth. But as you can see on the bottom of the graph, almost half of the babies require some treatment. And that can range from during pregnancy, have to receive intrauterine transfusion, or after birth, a top-up transfusion, egg change transfusion, and phototherapy just by itself or with associated with other treatments. So there is a risk for the baby. That's why we look at them. That's why it is important we have standard protocols and give anti-DIGG accordingly. The immunity D reported cases, so we start collecting them in 2012. So that was the first time, and we've been collecting since then. We separate into previous pregnancy and non-previous pregnancy. If there's a previous pregnancy and anti-D immunity D was identified at booking, the data from the previous pregnancy might be relevant, might give us the reason why there was a desensitization. And we collect information on the immunity D. We identified cases where there was poor management of pregnancy. If it was related of anti-DIGG error, we require then a second report that will be under the anti-D administration error category. But we also collect information where the management of pregnancy was ideal, and that is to give us information of what are the other contributory factors on the mother or during the pregnancy that can impact and can impact and contribute to the desensitization. Some of the cases, the factors that we look at is, for example, delivery beyond 40 weeks or a high BMI. And the idea of collecting this information is to hopefully inform and improve the current guidance. We have on the SHOT website a lot of resources to avoid, to help avoiding these errors. So we have these 2 shot bites. As Jenny said, cell-free fetal DNA is happening since 2016, and we have seen a range of errors happening. Also, we have a shot bite that explains the differences between the 2 categories and what are the cases where we need 1 or 2 reports. We also have some shot videos. As Claire said, we have issued this shot safety notice in December 2024 because the anti-D-IgG errors remain high throughout the years. We have also some email signatures that is with key learning message that is free for use and you can use on your emails. And I'm happy to say that in September 2025, so this month, we have the new anti-D cumulative data page. So on the SHOT website, we have one page where we have all of the SHOT data related to anti-D IgG errors, all of the resources from SHOT, and also links to the relevant resources related to anti-D. He also, before I finish this presentation, we have scheduled for April 2026 the National Comparative Audit for anti-D. Me, Jenny, and Claire have been part of the group, and we hope that this will inform on practice and understand the gaps. And thank you for listening. We are now going to move to the Q&A.
Thank you so much, Vera. That was fantastic. I'll just have a little look in the Q&A. Please do feel free if you've got any questions. There's only a couple there at the moment, but if you've got any, it'd be really, this is a great time to add your question in. So I'll read the first one that's been posted. This is talking about early pregnancy, like really early. So this is talking about a 5 to 6 weeks pregnancy with a PV bleed and pain, and should anti-D be given? I think there's some discrepancy in the local hospital whether that should or should not be given. The patient's not had a scan, and they're asked to do a follow-up appointment in 2 weeks, so they're not sure, they're getting conflicting advice. Any comments on that one? Maybe Claire, from a clinical perspective?
Hello. Yeah, early pregnancy, it's quite challenging because the guidelines do differ between the British Society for Haematology and the NICE guideline. They do say different things. So if you're going by the British Society for Haematology, it does advise that if you've got PV bleeding or vaginal bleeding under 12 weeks, if it is associated with abdominal pain, they recommend that you should give the anti-D. The other situations in early pregnancy, with, for example, ectopics, that does differ from the NICE guideline. BSH recommend you give it, and at the moment the NICE guideline recommends that you don't. So it's complex between the two. But yeah, bleeding with pain, you should ideally be giving anti-D.
Thank you. That's really great. I'll pass on to Vicky. Oh, sorry, Vera. I think would you Vera's like got to something to add? Yeah.
Sorry, so we are aware of the discrepancies, and we have received reports where the anti-D was not given exactly because of that. We know the BSH and the NICE guidelines are currently under review, and then we'll update our criteria accordingly to the advice from the guidelines. But we are aware, and we're making the best efforts to try to address these discrepancies. Just to say that. Thank you.
Just to quickly clarify, sorry, the NICE guideline for the ectopic pregnancies, you would give the anti-D for surgical management, but not for medical management. And that they've got a statement saying that they're actually reviewing it as well themselves.
Great, thank you, Claire. Thanks for that clarification. It's really important we get it all out there. The next question we've got in the Q&A is more of a technical question, but the question is, why is it 72 hours essential for the administration of anti-D? So why is that particular time frame being identified?
I can
go on,
yeah,
Claire,
I'll go again.
Nominate you again, if that's okay.
So the 72-hour time frame is the optimal time when it's given, particularly if it's given IM, for it to be absorbed in the bloodstream and to provide the response we want it to. If it's given IV, it's a much quicker immediate effect. So if you had a very large fetal maternal hemorrhage, IV might be the way to go. And thinking about the 72-hour window, what's really important is the site of administration if you're giving it IM. Now, we recommend the deltoid because you're more likely to hit a muscle. So there's situations, for example, with a very raised BMI, if we give it into another muscle, there's a chance that we're going to administer it into the subcutaneous fat, and that will take much longer to be absorbed. And then even if you've administered it within 72 hours, it may not be absorbed and performing as it should within that 72-hour window. So choice of sites is also really important.
That's great, thank you. Another question, this one is probably for Heather. It says, we have a brief overview of the new labnostic feature that we talked about. I'm assuming that's to do with the cell-free fetal DNA. Thanks, Heather.
Okay, no problem. A very brief overview is that the hospital LIMS is connected to MPEGs or labnostic, and the test request goes through to that. Then that labnostic is then mapped to the system at an HSBT, so Hematos, and the request goes through to them, and the result is resulted in Hematos, and then that pings back into labnostic and then back into the hospital LIMS from where it originated. So that is a very brief overview. It does, some LIMS do need a bit of configuration sorting out, but we are working with several different suppliers now, so we are sort of sorting those issues out. But if you want any more information, then please drop me an email. I'm sure the girls can share my email address to you all.
Absolutely. On a side note, so Heather, have you got quite a lot of hospitals who have taken the opportunity to join and link with labnostics?
Yeah. So currently we've got 66 sites that have got the functionality enabled, and 38 of those are now actually referring the samples electronically, and the others are bringing up the rear. So, and then we've got quite a few more in progress as well. We're hoping to have about over 100 by the end of this financial year.
Thank you, Heather. All sounds very positive. Sorry, unmuting then. So the next question we've got is related to partial variant Ds. So Catherine said they've got problems noticing incidents related to partial D where the patient is not noted late on to be a variant, so not identified from the very start. So we've had some issues with communication with this to patients and wondered if there's any information or guidance about partial variant Ds and communicating.
We have received, sorry to jump in, I should have put my hand up. We have received some incidents because obviously the technology, it is improving, and sometimes the D variant is identified exactly because the lab changed the methodology, and that is when it is identified. From the shot, there's no plan information. Claire then can make an input from the PBM side. I think before, the D variant is quite complex, and I think even the clinical team and sometimes the laboratory are not really aware of what is so many variants and how can it be impact. So I think the first step is still that education on the clinical and lab stuff. So I understand explaining that to a patient, it might be difficult because sometimes it is difficult to explain to our own staff. I know I had that issue before. So from the shot, we have highlighted the complexities of anti-D on the immunity D chapter because we had a patient exactly with that problem. But we don't have anything on the patient's information page, for example, on the shot website about the variant. I'm not sure if Claire is aware of anything from the clinical side.
No, unfortunately, I'm not, Vera.
Yeah. So I think the answer it is no, not at the moment.
Thank you. There's a question here
From Jonathan, in 2019, there's a complete change in management of abortions where medical abortions less than 10 weeks were no longer tested, and that was extended to surgical medical for greater than 12 weeks this year. And NICE are about to, I know we've talked about this, NICE are about to review their miscarriage and ectopic documentation at the moment. But so from our perspective, looking at our data, have we noticed any change in reports in the sensitization during that time? So since the guidelines changed, have we seen a rise or fall or a change in our numbers reported? Anything over the last 5 years that you've started to see a trend in? Do we think?
Jenny might be able to answer because she's been there for long. I've been looking at NTD for 2.5 years, and I don't think we have seen an increase. We have seen an increase of reports highlighting the discrepancy between guidelines, but I don't think so. Jenny?
Yeah, I was going to say, I don't think we've seen any changes, particularly in reporting or increases, but we have noticed increased number of questions coming through about the guidelines and the disagreements between the guidelines. I think that's more where we've seen changes as opposed to the actual data itself.
Yes, brilliant. So it's not reflected in the data, but we've seen it from more queries from reporters. Thank you.
Fab. Thank you. So the next question here is about immune anti-D. So it says half the babies with immune anti-D needed some treatment. So do you know if there's any plans to review the monitoring or the management or any improvements that can be taken from the data about that?
The plans is to do a 10-year look back. Actually, it is more than 10 years. Since 2012, we are currently doing a look back on all of the immunity D cases. I would say the questionnaires, we are trying to increase awareness because even when it's needed two reports, most of the reporters don't know that two reports are needed. So I've been trying to contact. So we are trying to do the look back and see if we can identify contributory factors, any gaps that contributed to the immunity D. But it is currently undergoing. But hopefully it will be in the next. It is a lot of data, that's what I have to say, and there's a lot of gaps that we find on the data that it has been collected so far, but we hope that we get some answers from that look back.
Super. So this is a question within ourselves, really, I suppose. This is about the actual SHOT questionnaire, the questions we ask of our reporters while we're filling them in. It said sometimes it can be difficult to answer. The question is there any plan to review those questions that we ask of our reporters?
Every year we will look at the dendrite questionnaires, and it's at this point that where we are looking how we can improve. If there's anything that is not clear, that you think it's not suitable or it doesn't make sense, just let us know, because I've been collecting feedback from reporters, and that is what we look at this point, what the reporters are finding difficult. We understand there's especially, we receive cases where the immunity D was identified at booking or even during the pregnancy, and the patient had a previous pregnancy, and we ask questions about the previous pregnancy, and sometimes the patients came from a different area or the pregnancy was in a different country, and we completely understand that the information might not be available. Sometimes I might be chasing if you have the information, if it's possible to have that information, because without the information we cannot actually analyze it. But if you feel at any point that any questionnaire is not just for the immunity D, if there's any questionnaire, any question that you find difficult that could be reworded, or some information that we are asking and really it doesn't make sense, just drop us an email, because we are reviewing, as I said, we are reviewing the questionnaires and the definitions every year. So if your feedback is what makes us change, that's it.
Yeah, absolutely. And that's not just for anti-D, is it? If there's anything
Mm-hmm.
for any question you're not sure about the answer is, absolutely, please do get in touch. Thank you. Shall I hand over to Vicky?
Fab. Thank you very much for that one. So the next question from Bushra is about continuous bleeding. So they're saying if there's continuous bleeding and we give anti-D every 6 weeks, is there a point where they should stop giving the anti-D?
good question. Yeah. So correctly, if you've got continual bleeding, you're going to give anti-D every 6 weeks. Once someone gets to 20 weeks, you're then going to do fortnightly fetal maternal hemorrhage sampling. If you continue to see fetal cells, then you would give further doses of anti-D, and you would give this in exclusion of the routine antenatal prophylaxis. So that would be given as well. And whilst all this is going on, if the person presents with a new clinical situation, for example, they had a knock to the stomach or something, you would treat that as its own unique, potentially sensitizing event. And so you would give more anti-D and repeat the fetal maternal hemorrhage sampling, and you give anti-D regardless of the presence of regardless of the presence of passive anti-D. The question of when do you stop would have to be completely based on that individual person's clinical situation. Obviously, with like no fetal cells seen, no further bleeding, and everything's completely stopped, that would just have to be weighed up independently, the whole situation with that person. I don't think the guidelines actually state when to stop, from my recollection. I don't believe there is a stop date in there, so it's individual basis.
Thank you so
Clare.
much, Claire.
Oh, this is a slightly easier one compared to that obviously very complex situation, and I think you probably see this a lot, don't you? If anti-D is administered, so routine antenatal prophylactic anti-D is administered, and the person reports a potentially sensitizing event a few days later, is more anti-D required, or is it covered by the routine antenatal anti-D? I think that's probably something you see quite a lot, isn't it?
Yeah, that would be a case of you treat it as a unique event, and you would treat that PSE with the right amount of anti-D at that time, regardless if it was just a couple of days ago or even the day before you'd had the routine. The potentially sensitizing event is its own unique situation and should be treated exactly as that. So she would need more anti-D.
And that, just to join it, sorry to interrupt, Vicky, and that it is, if the PSE is after or before, you should always treat it. This is cases that we see. So if you have a PSE and you give anti-D, that dose is not associated to the RRDP. You still need to give to RRDP, as Claire said. Thank you.
No, great. Thank you, Vera. It's really important to clarify that as well. This next question is, I think it's on the same theme that we've just been discussing about the 6-weekly bleeds. So it says, what is the recommended approach for administering anti-D in pregnant women with recurrent antepartum hemorrhage who require weekly blood tests, considering the Royal College guidance advises administration every 6 weeks, while the lab in this place has suggested issuing it at weekly attendances? Is that something, to comment on?
I mean, I suppose every hospital will have its local policy, its local guidance. We're obviously speaking to the national guidance. So the national guidance is every 6 weeks. And then if you have additional individual potentially sensitizing events. But I kind of feel like with anti-D, more is more. It's when you don't give enough that the problems are really occurring. So I can't speak to an individual local hospital, sorry.
I think from SHOT data, I think we'd always say follow your local policies, bring that up internally if you feel it needs reviewing and things like that. And things that are reportable to SHOT are things that fall outside of national guidance, not outside of local policy, just from the reporting side of things. Fab. Thank you.
Super. So the next question, we're talking about a non-compliance of the patient. So in a patient that didn't receive anti-D because the patient didn't attend an appointment, is that still considered non-compliance and reportable to SHOT?
We received some queries about this because the current reporting criteria says to not report if it's a patient's non-compliance. But then what is a patient non-compliance? We need to ensure every time we receive a report and they say it was because the patient, the mother, didn't come to the appointment and then it was not compliant. I always come back to the reporter and ask if the patient did that decision or refused anti-D based on a well-informed decision. Has the patient had given all the information, or the patient didn't comply, didn't come to the appointment because she didn't even had the information about the importance of receiving anti-D in a timely manner. So the non-compliance needs to be considered carefully, because sometimes we need to understand why the patient did not comply. We understand some of the cases the patient has all the right to say, no, I don't want to receive it, and we need to respect that, but we need to understand the reasons why the patient has not received or decided to refuse receiving anti-DIG.
Thank you, Vera. So it's not quite black and white. Yeah, brilliant. Thank you.
Great.
And also,
next question.
sorry, I was just going to
Sorry.
say also, if the woman has been offered another appointment as well, if they didn't turn up to one appointment where they offered another appointment, could they get to them? We need to think about that as well, the actual maybe feasibility and logistics of getting to appointments can sometimes be a bit difficult. So just not attending one appointment may not be non-compliance, if that makes sense.
No, absolutely. Yeah, it's very complicated if somebody's got to be given the chance to have the treatment if it didn't work. That's really interesting. Thanks, Jenny. Next question is about traceability. So should the same consent and traceability processes be applied to anti-DIG as for other blood components?
I'll go first. I was just waiting someone would come. Yes, obviously the administration of anti-DIG, the woman or the person that is about to receive the anti-D should understand the risks, be well informed, and consent before the anti-D is administered. And also the traceability is very important. We received reports where the traceability was not carried out properly, and we received those cases because it means there was a gap in the local processes. I don't know if Jenny and Claire wants to add.
Yeah, traceability is really important, especially when you're testing women post being given anti-D. You're detecting anti-D in their plasma, and then you really need to know when they had that anti-D administered to them. So not just from it's a blood product and it's been transfused to somebody, but also in terms of making those decisions about whether you're detecting passive anti-D or immune anti-D at those tests as well. I'll let Claire talk about consent process though from the clinical side.
So obviously we need to make sure that before anybody receives a product, they need to understand the benefits and the potential risks, and that conversation should be supported with written information. We could possibly there is a national information leaflet for anti-D for pregnancy, but I don't know if we can pop that link in the chat perhaps, but that's available, and that should be documented so that you've had that conversation before you give that person their anti-D. So yeah, we should be absolutely documenting it in either the handheld or electronic record, whichever one you've got.
That's great, thank you. Really great answers. There's a question here that somebody feels there's again some gaps in advice from national guidelines. So if a patient has a laparoscopic surgery while they're pregnant, and do they require anti-D? In the particular local area, the surgeon felt that it was not required as there was no abdominal involvement. They feel the guidelines do not give clear advice on that. So any advice from us, guys?
I completely agree. There isn't advice linked to that. It's where you can look at anything that kind of is interfering with the uterus, for example, amniocentesis or something. That's an absolute yes. It's clear, crystal clear in the guideline. You should be giving it. But other abdominal surgical, you ideally are going to err on the side of caution, aren't you? Because when you're doing that surgery, there is that risk of interfering, causing some movement or trauma. But yeah, it's not clear. So I don't know if Jen or Vera have a take on it, but it is definitely a gap.
I agree with you, Claire. It is a gap, it is unclear, and erring on the side of caution, I think, is always the laboratory's approach. We will always offer anti-D and then see if the clinical decision whether they want to give it or not.
Yeah, thank you. Thank you for those answers.
Fab, thank you. So I've just we've got a follow-up question about the conversation regarding immune anti-D and about treatment and monitoring. I think it's treatment monitoring of the mother during pregnancy that was asking about. Is there any going to be a look at any of the guidance for it? So this person's asking, what's the advice at the moment with immune anti-D and advice apart from monitoring 2 samples and changes? Is there anything else to be looking for to determine the likelihood that the child would need treatment or intervention once they're born?
If immune anti-D was detected during the pregnancy, they should be closely monitored for the levels. So the sample should send to the reference lab, and they should do a scan as well to understand what are the risks of hemolytic disease of the fetus and newborn. Obviously, this should be a part of the local protocol. I don't know if there is any review of how they should be managed. At least I'm not aware of. But obviously, if the immunity is present, especially when it's high levels or there was an increment of more than 50%, usually there's a quick action from the reference lab to inform the laboratory, and the laboratory should inform as quickly as the clinical team to act and do the scan and understand what are the options. However, I'm not aware of any review currently being done. I don't know if Claire, Jenny is aware of any. Yeah, no.
Lovely.
No,
So
I'm
yeah,
not.
just as local that just that good communication, and then maternity services will have their own processes in place as long as that person's been flagged as high risk to be monitored. Fab, thank you, Nikki.
Yep, so the next question is, I know you briefly mentioned this earlier on, but is there any shot information relating to when to administer via IM or IV route for anti-D? And if there's if they're decided between the 2 routes, is the dose the same? So I suppose there's 2 parts there. Have we got any information from SHOT's perspective as well?
The guidelines, if I'm correct, it doesn't specify where they should be started to look at IV. It doesn't specify from 80 mils it is IV instead of IM. I don't think there is that information. However, if it's, at least from my experience, my previous experience in the reference lab, if it's more than 80 mils, it's when they start looking at giving IV. Not only IV, just not only because the anti-D will act quicker, but also the dose is different. So if you are giving by IV, it is 100 IU per mil instead of 125 IU per mil if you give intramuscular. So that will different. And sometimes I haven't seen much in SHOT, but from my previous experience, I have worked with cases where it was intramuscular, and then the advice is to give intravenous, and then there's a bit of miscommunication of what actually the dose should be. So that again, it comes the communication, how important it is to understand what are the differences when you give anti-D IM and when you give it IV. But usually it is the clinical team that needs to approve it is being given IV or IM. And also just to understand if the anti-D that you have locally can be given IV, because not all of them can be given. So you need to understand that as well.
Yeah.
If I can
Claire.
I'll just sort of add on to that. So obviously we know that if you've got a fetal maternal hemorrhage up to 4 mils, you're likely going to give that IM. Obviously avoiding.
I think I lost Claire.
So outside of a large fetal maternal hemorrhage, so 100 mils or more where you'd give IV, there's another group of people that you would consider it for. So anybody who's got severe thrombocytopenia or a clotting disorder such as von Willebrand's, you might want to think about giving it IV to them, because IM's just not going to be a very nice route for them to have it. So that's just something else to bear in mind when making the choice.
Thank you, that's great.
It's really interesting stuff that we don't obviously think about an awful lot from the lab side. So that's really interesting. Next question here is about the antibody screen. So it's saying, after giving anti-D, usually how long afterwards will it it says, will the antibody screening be negative? I'm wondering if they mean how long will it be detectable in the screen?
There is no clear, it can be changed from individual to individual, but usually it says after 6 months it clears out. But it can be, it depends on the dose that he was given. It depends if it was just one dose or if it was more doses. It will be dependent. Usually we think it's around 6 months. I think I'm correct. But Jenny?
Is the question, yeah, I was just going to clarify the question, is that how long will you detect passive anti-D post administration to the lady? Is that what the question is asking?
That's my interpretation, but the
yeah.
question itself asks how long will the antibody screen be negative?
Yeah,
but I think my interpretation may be around passive anti-D.
Yeah, mine too. Vera's correct. It does depend on the dose that's given. It also depends on what analyzer technology you're using as well, because some of those are more sensitive than others. So we generally say about 8 to 12 weeks post administration that we're likely to see anti-D still in the plasma.
Jenny really highlighted the importance of taking your sample before giving your RIDP.
Yeah, absolutely. Yes, and knowing when exactly when the anti-D was given as well is really important. It comes back to the traceability part again, doesn't it?
I'm sorry, Vera.
It's okay. Unfortunately, the techniques that we have available to the labs at the moment cannot differentiate between passive and immune, which will be really, really useful. But at the moment, it just appears as an anti-D pattern. So it is very important that you keep sending the samples to the reference lab so they can do the quantification and understand, because based on the result, it might be likely to be immune or likely to be passive. Again, when Jenny, just to reiterate what Jenny was saying, it is very important to know if anti-D was given and if it was, when, and the dose, how much it was given, so we can analyze or interpret the result that we get from the quantification with the administration history.
Thank you.
Great. This is a question for the SHOT team, asking about engagement with other clinical areas. So has SHOT engaged, or are we planning to engage with the midwifery networks to promote anti-D safety? Traditionally, anti-D has always been within transfusion. However, our levels of influence outside blood bank are not always realistic. So what about our engagement with other midwifery teams and networks?
I'm happy to speak. So obviously we've got the national comparative audit coming up, and normally that falls to transfusion practitioners for the bulk of those things, but we're very focused on asking the midwives to do this audit. We've already been out to the Chief Midwifery Officer for England and the regional Chief Midwifery Officers to talk to them about the audit and get their involvement. And once that audit is completed, we would be looking to take that back out to midwifery groups, looking at using their social media, their journals, looking at their conferences to try and get the message out there, really. So yes, we are, from that side of things, actively trying to engage. I don't know if Vera or Jen have got any other thoughts.
So within our own organisations, obviously it's really important to have that relationship with maternity services, midwifery and the governance leads, etc. So that if we are seeing any errors or near misses within that pathway, that we are talking, we're not just keeping it all within the transfusion department, but we're actually having those conversations with our midwifery colleagues and the governance routes as well. It's really important to make sure it's teamwork, isn't it, here with anti-D, really. There's lots of people involved, and so we all need to work together to make sure that we're improving things.
So just last question here, because we're running short on time. Just one quick comment is that somebody said that they've had a patient who became sensitized by an appendectomy at 17 weeks. So they're an advocate about anti-D. But the last question related to that kind of one and the teamwork question is that, oh, I've lost it now. It was about whose responsibility is it to make sure that additional anti-D is given and for patients to be called in. Is it lab's responsibility or is it the clinical area's responsibility?
Both, I think.
Yeah, both.
I think there's a bit of both there, that we all have our responsibilities. And as I said just now, it's teamwork, isn't it? It's all about teamwork and good communication as well.
Because one of the biggest things we see is discharge before administration. So from the clinical, we could say to look at your discharge form, if it is effective, look at your processes, but also from the lab, are you looking at the entities that have not been collected? There's a process. So just to look at the clinical and labs, and from my experience as I'm a biomedical scientist, my experience is sometimes the clinical and the lab don't work together. But I think that collaboration, understanding, and have processes that help each other, it is very, very important to make sure the process is effective, because we cannot just assume, and that doesn't happen just with the anti-D. We cannot assume because it came out from the lab, it is okay, we don't need to check. The same from the clinical, if the clinical has requested, so it is okay. So I think it's that collaboration and trying to build up relationships between the lab and the clinical team. Most of the times the TP can have a role in that. Not saying it is a responsibility from the TPs, not at all, but I say that it is a lot of healthcare professionals that can work in collaboration, and that the communication and processes that are effective, it is the way to improve transfusion safety and prevent errors.
Okay, thank you everybody for all those great questions. Apologies, we've not quite got round to answering all of them during the session, but if you've got any that are really burning and you would like them answering, if you send them through to us at the SHOT email address, which is shot@nhsbt.nhs.uk, we'll do our best to answer them for you. In the last few minutes of the webinar, we're going to do a live poll and would really appreciate you taking a few minutes to complete it, as it helps us to guide our future resources and webinars. So that will appear on your screens for you to submit your answers, and then at the bottom you should see a submit button. It's the first time we've done this on Teams, as Vicky said earlier, so hopefully that'll all go smoothly. While you're answering these questions, I'd just like to remind you that the session has been recorded, and the recording will be available to view within a couple of weeks. So for any staff who've not been attended today, then that might be really useful to know. We do appreciate your feedback and suggestions about haemovigilance and the work SHOT does. So please get in touch with us if you've got any ideas around resources or anything like that. And just a reminder that our resources are all freely available on the website, so you can use them if required in your transfusion education activities. Keep an eye out on the website and our app and LinkedIn for our next webinar. We do have one which is coming up on the 22nd of October, and that's all about the SHOT transfusion safety standards, which were launched in July this year. So that's your opportunity to hear all about those. And finally, a huge thank you to all our speakers today and to all of you for joining us. And we hope to see you again very soon.